Welcome to our Behavior Health Around the State educational series. LAMHA collaborates with our partners around the 10 regions of the state, all of which share similar missions to us. We're offering this series aimed at bringing attention to and education on key mental and behavior issues and initiatives affecting our individual communities. This year's Behavior Health Around the State series focuses on such topics as suicide prevention, youth mental health, gambling and substance use, intellectual disabilities, and developmental disabilities, LGBTQ+, and maternal mental health. We are very excited to bring experts from our local communities and from around our state to provide current and relevant information on these issues. In our 4th year, we are continuing to offer these educational series through our long-term partnership and support with the Office of Behavioral Health. We are also thankful to you as our listeners, as we look forward to hearing from you on what topics you feel should be highlighted as we continue to grow these educational offerings. I hope you enjoy today's topic and take away something new from our speakers. Please join us in the coming months as we discuss more topics affecting you, our communities, and those we serve. Thank you.
Hello, my name is Jan Laughinghouse. I am the Executive Director at Capital Area Human Services. Here at Capital Area Human Services, we are the single portal of entry for people who have developmental disabilities so that they can seek government-funded services to help maintain them in their community and at home. It is important that people who have intellectual and developmental disabilities get the support that they need so that they can be successful in life, community, and work. Intellectual and developmental disabilities affect people over a lifetime and are often present from birth and affect their ability to reason, think, learn, and have appropriate social interactions. Because of how they are affected, they actually have difficulties navigating society, and it creates anxiety, depression, psychosis, and other mental health issues. Today, you will hear from 2 experts from the ARC of Louisiana and the Office of Citizens with Developmental Disabilities on how we can support our citizens who have intellectual and developmental disabilities and mental health issues. I hope that this will be informative and that you will come away with the tools that you need to be of service.
I'm Dr. Brandy Kelly with the Office for Citizens with Developmental Disabilities. I have worked with individuals who have intellectual and developmental disabilities and behavioral health needs for over 2 decades. I'm happy to be here to talk with you about understanding better what behavioral health needs may look like in individuals with IDD and how we can make some minor modifications in assessment, diagnosis, and treatment so that they can access and benefit from the same types of treatments that individuals without IDD access and benefit from. Despite the fact that there was a time when individuals with disabilities were thought not to be able to experience other co-occurring behavioral health conditions, it's well established at this point through lots of research and clinical practice that in fact individuals who have intellectual and developmental disabilities have a greater risk of developing behavioral health conditions compared to their peers who do not have IDD. It's commonly accepted that over 1/3 of individuals with IDD will experience behavioral health symptoms. And since COVID, depression and anxiety rates have increased pretty significantly for individuals with intellectual and developmental disabilities. Individuals with intellectual and developmental disabilities also experience very significant trauma. And estimates are that 80 to 90% of individuals who have IDD will experience trauma in their life. Many individuals will have multiple trauma experiences, and over half of these individuals currently never access treatment for the trauma or the trauma response. If you look at data specific to our state, you can see that it coincides with what we would expect. In our most recent National Core Indicator Survey data, which is a survey done by the National State Directors of Disability Services Group, 25 to 35% of adults experience a formal behavioral health condition. 11% of youth have a formal behavioral health diagnosis. And 50 to 68% of adults struggle with some sort of self-injurious or destructive behavior, while 43% of youth struggle with self-injurious or destructive behavior. If we look at adverse childhood events data for individuals in Louisiana, we see that 90% of the individuals that we serve in the OCDB system experience adverse childhood events, and more than half of them experience multiple events. So again, you can see some pretty significant rates for behavioral health conditions and even greater rates of trauma that tell us that individuals with intellectual and developmental disabilities do experience these symptoms and problems, and they will need access to assessment and treatment. Because some developmental disability conditions do come with some cognitive and communication challenges, there could be modifications that need to be made. But these modifications do allow for the process of assessment and treatment to continue. I'm going to talk a little bit about some things that we can do when someone has some communication and cognitive differences that will allow you to feel more comfortable providing assessment and treatment services. We want to be sure that we allow sufficient time for the person to process and respond. So you may need to pause a little bit more. Don't rush the person, and don't attempt to finish what you think they might be saying. Don't assume that they're not responding. Give them a moment and let them have the opportunity to process the information and respond in a way that works for them. Be sure to use easy to understand language. As clinicians, we can often use clinical language, big words, compound sentences, and we really just want to keep it simple. And if we can make that adjustment, most often individuals will have a better understanding and they will be able to participate and respond. You want to focus on one concept or idea at a time, or one question at a time when you're doing assessment and treatment work. It's going to be hard for some individuals who have some cognitive or communication challenges to keep in their mind more than one concept or idea at a time. You want to be sure to use a blend of open and closed-ended questions. Some open-ended questions may be hard for people to answer if they have cognitive and communication challenges, so you may have to probe a little bit. But if we just use simple yes or no questions, sometimes the individual will end up responding in a way that is biased towards what they think the answer may be or what they think you want the answer to be. You want to be sure to use multisensory input. You want to use visual cues when possible, gesturing, role-playing throughout assessment and treatment when that's appropriate. You also want to be sure that before you begin any assessment or treatment activities, that you know if the individual uses any specific technology to communicate, if they use sign language, and that you have appropriate accommodations and have access to any of that technology. And then you want to ask if there are any other unique communication needs you need to keep in mind, and make sure that you adapt your communication style and efforts so that the individual can participate and respond. We'll talk a little bit specifically about assessment and diagnosis considerations. There are two manuals that are available that can help in looking at diagnostic modifications. The National Association of Dual Diagnosis publishes the Diagnostic Manual for Intellectual Disabilities. They are currently on the second edition. This manual is tied to the DSM-5, And it helps with some general assessment tips, but also looking at every diagnostic category and identifying the things that you might modify and considering the number of symptoms, how symptom presentation may change a bit so that you can feel comfortable making a diagnosis. The diagnostic criteria for learning disabilities is published by the Royal College of Psychiatrists, and it is attached to the ICD system. So it is often a useful resource if you're trying to make sure that you are assigning the diagnostic coding so that you can bill appropriately. So these are two resources that are available and can help you in making any diagnostic determination. When you are doing an assessment and you are looking at diagnostic considerations, individuals with disabilities can participate in mental status examination questioning. You may have to make some modifications. For example, someone's appearance might mean less if they are less independent in dressing and grooming. So you will need to know a little bit about the person's ability to do certain things for themselves each day. More complex areas may need to be adapted. So you may ask the person to count backwards instead of doing serial sevens. You may ask them to remember an object you showed them earlier instead of remembering 3 words that you told them earlier. Our Office for Citizens with Developmental Disabilities has some modified tips for completing a full mental status exam, and I will share some links at the end of the presentation so that we can make sure you have access to those. But know that you can conduct a mental status examination with someone who does have cognitive and communication challenges, and there are some simple modifications that can be made so that this is a useful part of your assessment. And remember that this can often help in looking at not only the initial diagnoses considerations, but it can help as you are looking at symptom changes and differences in presentation as you are engaging in treatment with someone. For an individual with IDD who has some co-occurring communication and cognitive challenges, observations may be a necessary and useful part of assessment, more so than it may be with someone who does not have an IDD with cognitive and communication challenges. Sometimes this will give you some indication of possible signs or symptoms of mental health conditions. So you may notice that someone seems avoidant. Maybe they look a little worried or afraid. Maybe they're shaking or pacing. You may see some mood changes that help you indicate where you want to explore further in your assessment. Observations can also help when you're looking at convergence of information. If the person has some trouble communicating, you'll want to be sure that what they are attempting to share with you verbally or in whatever manner they communicate is also matching with the observations you're seeing of their behavior and their mood and their interactions with anyone else who may be present with them. Individuals with disabilities will often have people in their life, whether it is family or staff, who help them every day, sometimes throughout their day. And because of that, there may be a necessary inclusion of other people throughout the assessment process differently than if the person didn't have a disability and didn't need this assistance. So you're also going to have to think about how you speak with the family and staff and include them in the process, and how you balance gathering information from them with also still making sure that you are gathering appropriate information from the individual. So you'll need to think about how you include other people, how you balance that with the information the individual is sharing with you. Where is information coming together and consistent versus where there might be disagreements and gaps and you need to explore further. Be sure that you don't assume that the information other people give you is automatically the accurate information. It may be a viewpoint and it may give you information that is useful, but you absolutely want to be sure that the person's contribution to the assessment is also taken as a priority. Once you can complete an assessment with an individual and perhaps settle on a diagnosis, then you'll need to think about therapy and treatment. Individuals with IDD, as I mentioned at the beginning, can participate in the same types of behavioral health treatment that individuals with IDD participate in. Many individuals with IDD will be able to participate in treatment and therapy with no modifications. Not everyone who has an IDD has cognitive and communication challenges. Some individuals have a disability that really has primary physical impacts. And then even individuals who have some cognitive and communication challenges, they will differ in degree. So you can always start from the perspective of how you would approach treatment and therapy in general. When you believe that you need to make some modifications because someone does have some cognitive and communication differences, these are some common things to think about. You may want to think about how you need to adapt your session length. Some individuals will need shorter sessions because they won't be able to retain a lot of information. And you're going to reach a point where they've sort of maxed out what they can do in that one session. Or they may just have trouble sitting in a session and paying attention for a really long period of time. Individuals who have some unique communication needs or use technology or signing to communicate may warrant some longer sessions because it may take a little bit more time to have the dialogue and to benefit from the session. Lots of times individuals with IDD are going to need more frequent sessions, and perhaps more sessions in number may take a little bit longer. They're going to need a little bit more practice in order for some of the skills that you may be teaching them and some of the coping strategies to really stick and be able to be used. You need to also remember that you may need to prepare the person for expectations in therapy. A lot of times the individual with IDD is not going to have self-referred themselves for your services. Someone else is going to sought services or treatment on their behalf. So they may have a different opinion and a different belief about their need for treatment. What is the identified problem may be different in their perspective than those who referred them. And you will need to keep this in mind and work with the individual on what their goal may be in therapy. You also want to consider using some visual agendas so that you can make sure that the person understands what to expect in each session and how the session will go. Remember that multisensory input and role playing can be especially important components in any type of therapeutic approach. Both cognitive behavior therapy and dialectical behavior therapy have clearly demonstrated effectiveness with some adaptations for individuals with IDD. And the most common adaptations are going to focus on more guidance by the therapist in the sessions, use of less abstract concepts, lots more practice and rehearsal, and often using role play, as I mentioned earlier. Our office also has some information on these modifications in more detail. And again, this will be available at the link that I will provide at the end of this presentation. There are some other evidence-based practices that are available in Louisiana, which individuals with IDD can benefit from when it is appropriate for their presenting condition. And you may or may not provide these specific evidence-based practices, but you may be assessing someone and needing to make appropriate referrals. So wanted to share this so that you know the types of treatment approaches that you can feel comfortable recommending, just like you would if you were perhaps assessing and recommending such a service for someone without IDD. Multisystemic therapy can be beneficial for individuals with IDD for similar types of challenges that multisystemic therapy might be recommended for someone without an IDD. The core components of MST are actually very consistent with many of the practices that we use in the IDD planning and support system, including looking at contextual variables and individualizing support, meeting the person where they are, in their home, in their community. It's also important to know that the agency who actually certifies MST teams has MST ID certifications and MST ASD certifications for individuals with intellectual disabilities and autism spectrum disorders. There are individuals in Louisiana who have an IDD who actually do access and benefit from MST. So when it is appropriate, you can feel comfortable making a recommendation. The same is true for assertive community treatment. We have individuals in Louisiana who do use and access this service for the same types of issues that you might recommend them for someone who doesn't have a disability. There are times when behavioral consultation from someone with experience treating an individual with IDD and behavioral health can also assist the assertive community treatment team. And that can be accessed and provided, and I will share some information related to that near the end of the presentation. Eye movement desensitization reprocessing is also an evidence-based practice available in Louisiana that individuals with IDD can access and benefit from. Remember that in this particular therapeutic approach, there is not a high requirement for any significant verbal skills and interactions, so that makes it a type of approach that individuals with communication challenges can easily participate in. It is true that it may involve a little bit more direction from the therapist during the sessions for the individual's benefit. Trauma-focused cognitive behavior therapy is also available in Louisiana, and similar considerations in terms of modifications, as I noted for CBT, can allow individuals with IDD to participate in this particular approach. Triple P parenting is the final evidence-based practice available that you may want to consider when appropriate for young kids. There is also a Stepping Stones IDD certification available from Triple P. I mentioned that we do have some tools and tips available that can assist you as a clinician or as a clinic provider. These tools and tips can be accessed at the link here. We will make this link available to everyone participating. The tools and tips can be accessed in real time, and we update this link on a regular basis. It includes information on some of the modifications that I shared in more detail related to assessment and treatment. It also includes the mental status examination modifications. It includes some tools you can use to look at various types of trauma considerations and other issues for individuals with IDD, so that you can be sure to consider any unique considerations. It also includes links to purchase the DMID should you elect to do that, as well as to some white papers related to the evidence-based practices that we mentioned. I'm going to end my presentation talking a little bit about the OCBD Resource Center. The OCBD Resource Center operates across the state. These are a group of clinicians that I supervise who practice across disciplines. The majority of our clinicians are behavioral health clinicians. We do have access to allied health clinicians and nurses when there are multidisciplinary issues. The mission of the Resource Center is to build community capacity to support individuals with IDD and other complex needs. So we focus very much on individuals who have IDD and co-occurring behavioral health needs. We are not a specific clinic or a direct service provider in general. We are focused on working with clinicians and providers so that you can become more comfortable serving individuals with IDD and behavioral health needs. We are available for consultation to a treating clinician for complex assessments or treatment modifications, and that can include a treating team, as I mentioned, relative to assertive community treatment or an MST team. We also are available to provide more in-depth training, and we do offer continuing education throughout the year on a variety of topics, including assessment and treatment for individuals with IDD and behavioral health needs. So we are available, and we can be reached at the OCBD Resource Center webpage or at resource.center@la.gov. It has been a pleasure to present to you today. I look forward to our opportunity to talk as a panel. Thank you.
My name is Ashley McReynolds. I am a parent of a 16-year-old that has a diagnosis of an intellectual disability and also has a co-occurring behavioral health condition. I am a program director at the ARC of Louisiana, and one of my contracts is with the Southwest ADA Center located in Houston, where my focus is on healthcare disparities for the population, specifically with individuals with disabilities, including those with intellectual developmental disabilities and co-occurring behavioral health conditions. My goal with this contract is to identify disparities and barriers that this population faces, and then work with professionals, including physicians, nurses, social workers, psychologists, psychiatrists, individuals that would be treating this population to bring awareness to the barriers and the disparities that this population faces, provide them with pretty common sense tips in communication techniques and simple accommodations and modifications that they can make to their practice to ensure that these individuals receive equal access and adequate services to improve their lives. So I spoke briefly about being a parent. My son Cooper is 16. He has a rare syndrome called Prader-Willi syndrome, and also suffers from a couple of different behavioral health conditions. He suffers pretty significantly from anxiety, and also has a diagnosis of bipolar. He has struggled these last probably 3 years pretty significantly in finding a provider who was willing and able to treat him. We've struggled with medications, just in general finding services, especially when we reach crisis level, and we're unable to secure a bed for him when he was really in crisis. So it's really become a priority for me for this population. And so I'm thankful for the opportunity today to get to share some of the work that I'm doing with you. So let's just first start with the mental health of people with disabilities. There's all kinds of studies out there that show that adults with disabilities, individuals, youth as well, experience mental distress far more frequently than those that do not have a disability. So you can see here in 2018, 32.9% of adults that have a disability reported frequent mental distress. And that is defined as 14 or more reported mentally unhealthy days in the past 30 days. So these individuals are spending about half a month at a time in mental distress. We all know that, with mental distress comes with extremely poor health behaviors. You utilize health services far more frequently, and most of those are more expensive because they're in emergency department settings. This affects, of course, chronic conditions and acute conditions, and really limits individuals in their activities of daily life. So prior to 1960, it was believed that individuals that had an intellectual or developmental disability were just not capable of having a co-occurring mental health condition. And they also believed that these individuals would not benefit from the same type of services that people without disabilities, when they went to receive treatment for behavioral health conditions, could actually benefit from. Some of the most commonly recognized conditions co-occurring are depression, anxiety, bipolar mania, and then psychosis and schizophrenia. While it is very much recognized that there is a very high prevalence of behavioral health conditions among individuals with IDD, there is very little known about the best approaches for the needs of these individuals and the challenges that these individuals and families face. So it is known that people with intellectual developmental disabilities are more likely to be impulsive. They're going to have several co-occurring medical problems, not just IDD and behavioral health. They're going to have several medical complexities. They are going to demonstrate challenges in any type of self-monitoring and self-regulation. They're also going to have difficulty with problem solving. They are going to have limited self-calming skills, and then also have limited language skills, which can make your everyday treatment for behavioral health conditions a little bit more challenging. So on top of just the behavioral health IDD co-occurring, there are also other risks associated with this population. They are at a much higher risk of having physical health conditions, which then can also contribute to an increase in the risk of other mental health conditions. They have for a very long time had their symptoms of a behavioral health condition being misattributed to their intellectual or developmental disability, rather than being recognized as a part of the manifestation of the actual behavioral health condition. This population also experiences much higher rates of physical and sexual abuse, which can then also magnify their vulnerability when it comes to behavioral health. So here's where we are today. Because of all of this uncertainty, unfortunately, it has led to the dependence of very outdated and honestly, just really bad approaches to mental health care for this population. It has led to the use of restraint and seclusion of these individuals, the overuse of psychotropic medications, which can actually cause this population to further struggle with anxiety and some of the other behaviors that come along with their specific mental health condition. It puts a very significant strain on any family support or natural support that these individuals receive, because they're left with very little services available in the community that are able to provide the proper supports to keep these individuals in their homes and in their communities where they want to be. So I have some Louisiana facts. According to our last census, our population is about 4.7 million. And almost 4% of that live with serious mental health conditions, such as schizophrenia, bipolar, and major depression. So nearly 1 in every 5 adults. Compared to the rest of the US, we are higher. So we have 21.2% of adults in Louisiana with a mental illness compared to 19.9. And then when you look at our Medicaid population, there were in 2019 about 40,000 hospitalizations due to a serious mental illness, which is quite significant. If you don't know, there was a Department of Justice investigation that was done, and they found that the state was improperly relying on nursing facilities to serve individuals with a serious mental illness or behavioral health condition, instead of providing these services in an integrated setting that was most appropriate to meet their needs. So this led to the Department of Health entering into an agreement with the DOJ that was very specifically detailed and outlined all of the expectations regarding these activities related to those that were residing in nursing facilities, and also just our overall behavioral health service system. And it required them to develop a crisis system of care, which we did not have prior to this Department of Justice finding. When you look at just some more facts, we rank 45th in the US for access to mental health care. So that's in general, that's not specific to individuals with intellectual or developmental disabilities. That's the general population. When it comes to individuals with an intellectual developmental disability, that number is actually probably worse, probably might be 48th or 49th. There's a big reluctance for clinicians to see individuals with an intellectual or developmental disability. But we'll talk about ways that we can sort of break down the stigma around physicians not wanting to serve this population. But when you look at some further statistics, 61.8% of those that report having a serious mental illness, they report receiving absolutely zero mental health treatment in the state. So OCDD, or the Office for Citizens with Developmental Disabilities, does a survey every year. It goes out and it's referred to as the National Core Indicators. This data runs behind, so it's not that I don't have more up-to-date data, just the data coming in is delayed in reporting. So the most current data that I have is from 2018, 2019. And so these are individuals that have a diagnosis of a intellectual developmental disability. And in the adult survey, we had 25% of adults reporting a psychiatric disorder. 50% reported self-injurious behaviors or disruptive or destructive behavior. When we looked at the results for the adult family or the guardians who filled out the survey, 35% of them reported having a psychiatric disorder or diagnosis. 68% reported supports for self-injurious and disruptive or destructive behaviors. So they had a need for these types of supports, but were not able to find them. And for the child family, 11% reported having a psychiatric diagnosis, and then 43% reported the need for supports for the more serious behaviors. So overall, these are more statistics that were done in a different survey from 2017-18. And I don't need to go through all of the numbers, but you can just see overall the statistics and the prevalence of having a significant mental health or behavioral health challenge in individuals with intellectual disabilities is very prevalent. And unfortunately, the supports and services for these individuals are not available in the community, and they are also not available when a person enters a crisis situation. So how did we get to this, to where we are? Our previous administration started about 15 years ago when budget cuts were made, and this the state closed the only 2 inpatient facilities that were available for inpatient treatment for these individuals. They were staffed with physicians, nurses, psychologists, other allied health staff that had the knowledge and expertise to provide treatment to these individuals. We had a stabilization unit, or an SU, and we also had a developmental neuropsychiatric unit, or the DNP. What's really needed now is, again, something specifically to treat this population, but we also need services across our entire continuum. We have to have better access to community-based treatment. Right now, it is very limited, and families report what's available is just not meeting the current needs of their loved ones. So some of the needed services are therapeutic respite. There are, I think, about 7 center-based respite facilities across the state. Unfortunately, these facilities are very hesitant in serving individuals that have sort of violent or destructive behaviors. So the one thing that is available for these families, these facilities are just not accepting this population, leaving individuals and families to struggle alone. As a family member, as a parent of a child that has very significant behaviors, I can tell you that we definitely struggle alone. We tend to hibernate in our homes out of fear of bringing them in public and having behaviors, people not understanding the behaviors, police and law enforcement not understanding the behaviors, and it really just becomes extremely isolating for families. What has also occurred is the state is actually paying to send individuals out of state. I know families that have gone to Kennedy Krieger. I know some other families that have traveled over to Texas Children to receive inpatient care and treatment. They are also admitting individuals into Pinecrest up in Alexandria. And that alone costs about, well, it's over $200,000 a year now, because we just don't have the proper supports and services for these individuals. We also have a very significant shortage in psychologists and psychiatrists, that just in general. And we also lack those that have the proper knowledge and expertise to serve this population. Okay, so when I've talked with parents, individuals with disabilities, the key issues that they always are bringing to the forefront is that our mental health professionals lack key knowledge about individuals with intellectual and developmental disabilities. The disability and the mental health care systems are extremely complex. They are not very flexible, and they often do not interact or speak to one another, leaving families having to navigate multiple systems to find, a continuum of care for their loved ones. When it comes to an individual having an intellectual developmental disability, these individuals report that they really struggle communicating effectively with their physicians. And when they feel like they're communicating effectively, they often report that they feel like the clinician or the physician does not, I guess, understand them in a way that they feel like they're actually being heard. So, and again, individuals that have a dual diagnosis, parents that have a young child or an adult that have a dual diagnosis, and then the other family members in that family unit always report feeling completely isolated, like they're alone on an island. And it's a direct result of the lack of understanding, the continued discrimination and stigma related to this population. So what are some of those barriers to the service system? I broke down the two service systems that this population receives services from. You have OBH, or the Office of Behavioral Health, and then the OCDD system, Office for Citizens with Developmental Disabilities. These systems have very little or actually no collaboration at all. So when you look at how these services and supports are different between the two, within OBH, the services and the supports are often short-term, based on acute onset of symptoms. Compared to the DD system, these services and supports are a continuum across the lifespan. OBH really only focuses on any type of psychiatric need, and the DD system, its emphasis is on direct support, so specific to the needs of that individual, related to activities of daily life. The OBH model, again, recovery model, medication, management, and treatment. The DD system is very patient-centered and does offer some behavioral support, but not to the level that is done in the OBH system. Overall, between both systems, there is a lack of funding for services. I will say in this current administration, there has been an emphasis on the funding for services for people with disabilities and those that have an IDD. We are in a much better place than we were 8-10 years ago. I mean, significantly better place. We also find that even when families find a provider that is willing to serve this population, it is very difficult to find when that individual's only insurance is through Medicaid. There are a lot of administrative and just bureaucratic red tape that makes it very difficult for the family and the individual to access service without a lot of hurdles that they have to get through before they get into the door to receive the service. There is very much so inconsistent crisis procedures, and this causes a lot of confusion for individuals and their families. They will be notified about a procedure or about a support or a service available. But then when they actually get and explain, this is what my child needs, this is, you know, their current issues, the provider may actually say, you know what, we just can't serve them. There is a very significant direct care worker crisis, which has put another strain on the system, and leaving individuals with intellectual developmental disabilities from receiving consistent support and care, which can also then have a negative impact on their behavioral health challenges. And then there's still a lack of accessible and public transportation. You know, this has been an issue, especially in our rural areas. Finding, you know, whether it's medical transportation or, you know, an Uber or a taxi or a Lyft, there aren't accessible transportation providers. And if there are, sometimes you have to try and plan for these trips months in advance. So just being able to access a provider is extremely difficult, especially in our rural parishes. So healthcare access, it is one of the biggest barriers for this population. The stats are staggering when you look at 1 in 3 adults with disabilities between the ages of 18 and 44 do not have like a general practitioner or an internist. They don't have that, you know, yearly check-in. They don't have a provider like that. 1 in 3 adults report having unmet healthcare needs, strictly related to cost. And it can also be due to that provider not taking Medicaid patients, because that might be their only form of insurance, which has led to 1 in 4 adults not having a routine checkup in the past year. And those were individuals who were between the ages of 45 and 64. So you've heard me talk about Medicaid. Unfortunately, it's not just a Louisiana problem, but here in Louisiana, it is, I feel, almost worse than the rest of the United States. Most mental health providers do not accept Medicaid, and that is due to the lower reimbursement payment rates. If they do accept Medicaid, you will often find that they are currently not accepting new Medicaid patients. So just when you think you found a provider that takes Medicaid, you'll call and try and schedule an appointment, and parents will hear, I'm sorry, but they're not taking new patients right now. And they'll sit on a waiting list. This is one causing a strain in emergency departments, because individuals and families are turning to emergency rooms for care, or when they reach a crisis situation because they haven't been able to get into their psychologist or psychiatrist. This population just doesn't participate in Medicaid and Medicare the way that other physicians do. A lot of them are cash only. They don't accept any insurance at all. So this is, you know, just another barrier in access. Individuals with disabilities, adults, most of them live on fixed incomes and cannot afford to pay out of pocket to receive behavioral health care services. And then we also see psychiatrists being selective about, you know, whom they're going to treat. So you may find if you're, you know, somebody that has a very mild intellectual disability, you know, they may be they may treat those individuals compared to somebody that might have a more significant cognitive impairment. So there's a lot of issues when it comes to providers, Medicaid, the cost to receive these services. It's just troubling. So part of what I do is, one, bring to light the issues that these individuals and their families face, and then try to encourage providers, our health plans, to one, just recognize that these are the issues, and then try to identify policies, more effective procedures that we can put in place together to create change for this population. So some tips when it comes to communicating with these individuals, just some important tips when you're dealing with them, when you're communicating with their family members. It is crucial that physicians understand just basic humanity, the dignity of people with intellectual and developmental disabilities that have a co-occurring behavioral health condition is critical. And without this understanding, we will never truly begin to enact change and enforce change and policies to better this population. You have to look at these individuals holistically, taking into account all of their skills, all of their abilities, all of the challenges, all of their needs, and taking into account every single corner of their life, whether there's, employment, education, the type of services they receive, the type of services that are available to receive in the community, religion, any other type of belief that they have. You have to look at these individuals, again, holistically. It's crucial that you fully understand that behavior is a type of communication, as well as temperament, and that they could be exhibiting behaviors as a way of communicating whether something is hurting, whether they don't like the way something is being, done, that it may not be directly related to their disability. It may not be them being defiant. And, you have to dig deep into that behavior to try to better understand what is actually going on with this individual. And then understanding and respecting that these individuals and these families are doing the best that they can with the very little that is available for them. It is very difficult as a parent to try to explain on a daily basis what it's like to live on an island, because that's honestly what it feels like. It's very difficult to be judged, to be ridiculed, and then to go into a medical professional's, office and try and explain this and just get some of these looks. And it's almost like we're being judged, again, by the very professionals that we're going to seek help from. So just being understanding and respectful of the family. We really are doing the best that we can. It is not that difficult and we're going to talk about some different ways to do this, to make treatment accessible to people with an IDD. There are coping mechanisms, there are motivational techniques that can very much be modified to these individuals so that their treatments can be successful, and that these individuals can leave feeling encouraged and with some positive feelings that, one, they're being heard, two, they've got somebody that has a plan that can try and help them, and that they're going to put an effort into their treatment. It's super important for physicians to recognize their limits, and understand that you may not be working well with this individual with an IDD. And then how do you look for somebody and help them find a new provider or a new clinician that can better help them, instead of just saying, this isn't working, I really can't see you anymore. Because that's what's happening. What should happen is that it's okay to recognize that this is just a little bit over my head, but I'm going to help you find somebody that can, instead of just dropping them without looking for someone else to sort of pick up where you have left off. So some of the most important things that when I talked with families and individuals, these are the most important things that these individuals wanted professionals to know. They wanted professionals to help them build skills. They wanted their strengths and their successes to be identified by them and celebrated. And then also how to work with them and their supporters, their families, in relationship to de-escalation when they were in crisis. They wanted providers to know that they should be given choices about their healthcare, just like individuals without an ID are given choices. They also would like the physicians to recognize, their age and their capacity when it comes to this. And specifically family members talked about this as well, that the individual with the disability should always be the center point, should always be in focus. But sometimes it might be appropriate to consult with family members if they are attending these appointments with the individual. They might have caregivers or support staff that are providing the day-to-day support for these individuals. So they may not have that family unit. It might be more paid staff, and it might be important to include them in some of the discussions as well. And then also, how can the physician help support this population when it comes to advocacy and self-advocacy skills, and helping and encouraging individuals with IDD to speak up for themselves and talk about, their wants, their needs, their desires, and make sure that they are kept at the forefront of the discussions. So let's talk about some simple communication strategies that individuals, clinicians can put into place to help improve the sessions. It's important that even if there is a family member or a paid caregiver in the room, that the physician or the clinician speak directly to the person and communicates information in a way that the individual understands. And that may take some effort. You might have to break things down into, much smaller steps. You may need to put things in writing and create, bulleted, instructions, or, this is, write out step by step. This is what we're going to do. This is where we're starting. This is our end goal. And here's how we're going to get there. To increase your chances of a rapport with this individual, you need to use their name frequently and refer to them with their name frequently. This has been shown as a technique to help, again, develop that rapport. This will make that individual feel more comfortable speaking directly with you, which will then improve the overall session and hopefully lead to better outcomes. Actively listen without trying to, ascribe any type of challenges that might lead you to a diagnosis. So sit and listen, very actively to this individual. Let them finish their conversations before you try and immediately diagnose them with something. It's super important to sort of plan for longer visits. Sometimes the individual, when they call and set up appointment, it may not be known that this individual has an ID. If you aren't made aware of it until they come in for the appointment, it might be difficult for that very first one. But going forward, your standard 15 to 30 minutes, sit down, here's what's going on. We're going to make changes. We're not going to make changes. It's not going to be successful. So you need to plan accordingly to allow, a longer visit, to allow the communication to flow freely back and forth. Speaking slowly and allowing the individual time to process maybe what you've said or what you've asked them is important. These individuals with IDD take longer to process and sometimes reply to a question that's been asked of them. So don't, if you don't get a reply in 3 to 5 seconds, don't immediately jump into and repeat the question again, because then you're just going to confuse that individual even more. So ensuring that they have time to process what you've said and then respond is also important. Again, I talked about this a little bit before. Just communicating respectfully, and looking at this individual holistically, taking into account any type of cultural or religious beliefs is super important. It is also crucial to giving these individuals a very realistic picture or description of all of the treatments options that are available. Going through and explaining the pros and cons of each. Even if you don't have time to run through everything in that one visit, providing them with materials that they can take home is recommended, because then the individual, along with their supporters, and it could be paid staff, it could be their family members, it might be a friend, they can then go back with that individual and go through all of them and look at all of the pros and cons before deciding on what treatment would be best. And then another good thing is looking at all those individuals, to their friends, their family members, paid staff, and any other professional that might be a part of their medical team, to be a part of, a more team approach, and making sure that you've got the different systems talking to one another to ensure that this individual receives a full rounded healthcare approach. So adapting the clinical approach is not as difficult as a lot of people think. The data and the reports are very clear that individuals with intellectual and developmental disabilities very much do benefit from the same type of clinical approaches that individuals without an intellectual and developmental disability do. So it's proven that it works, but it is going to take possibly some small modifications and accommodations to make it work. So these are just some general tips and general things that you can do to make some minor accommodations. Simplifying any type of appointments and the referral process is, because that can be very difficult and strenuous. The amount of paperwork that is required often to fill out, if you can send that information and all that paperwork ahead of time to the individual, so when they get there 15 to 20 minutes prior to the appointment, that might not be enough time for them to fill everything out. If they can have, a couple of days to maybe a week in advance to get that filled out, that would be great. reminder phone calls if you can't, get the individual, maybe look at a couple of different options to ensuring that they'll show up for the appointment. So it might be, contacting, a family member. It might be their paid direct staff. Anything that you can do to ensure that this individual gets there. Doesn't take a lot, but it does make a difference. Again, looking at the extended times, so making the appointment longer is also going to be important. If the individual has some sensory issues, some anxiety, long wait times is very difficult. It will cause these individuals to have an increase in anxiety and other things that can lead to some behaviors. Also, high stimulation environment. So if there's a lot of people in a waiting room, if there's like a quiet room or a space that the individual might want to go to, they don't have to, but having it available will also benefit how the appointment actually goes. And then when looking at appointments, what works best, for that individual, time, location, if they can be, first in the morning, or the very last one in the evening time. So the waiting room isn't full, of people. If maybe the doctor's office isn't the best location for them, is there, a central meeting location where this individual might open up and be more, open to communication, feel more comfortable, and just in their environment and be able to benefit better from the services. So anything that you can do sort of above and beyond, booking that 15 to 30-minute appointment. If things run over, the individual's just left sitting in a waiting room. There's not a lot of communication from the staff when you walk in to check in for your appointment. Hey, he's running behind, a certain amount of time off. If you are running behind and this individual struggles, and is a stickler to time, does not like, a lot of people in a waiting room, make sure that the when you check in, let them know that this individual, you're running behind, offer them to maybe, leave, go to a different, area in the office, and come back. So they're not just sitting and waiting. Avoid any, late last minute cancellations, or any type of short notice. So if possible, prepare the individual for change. So if they're coming later in the afternoon, you're already running 45 minutes to an hour behind, calling them and letting them know that they're running behind before they even leave, could greatly benefit that individual. So not just sitting in there waiting, they can maybe stay, at home or stop somewhere prior to the appointment and do something maybe that they wanted to do prior to coming in. Preparing ahead of time for any type of communication needs that this individual has is crucial. Making sure that if they do have a different way of communicating, that you have all of that in place prior to them coming to the appointment. If the individual requires an interpreter, making sure all of that is set up ahead of time so the appointment can go smoothly. And then any type of physical supports that the individual might need, if they have a physical disability as well, making sure that everything is completely accessible. It also addresses any type of sensory needs, will also just help that individual have better success for the appointment. One thing that I hear from families a lot is the need for the doctors to have a better understanding of the system and how these individuals receive support from the systems. understanding how our waiver system works. And, you know, how OCDD and the Office of Behavioral Health don't have a lot of, you know, communication or overlap. Understanding, you know, different acronyms that come with both systems, the different languages that are used across the systems is important. And then understanding all of the community resources that are available to this population and their families. So any, you know, think of, you know, the different ARCs, chapters of the ARC of Louisiana, Families Helping Families. All of these local community resources could really be important for families when they're trying to navigate these systems. And then, of course, understanding our disability laws. So the American with Disabilities Act has some very, if you just Google the ADA in healthcare, it has like frequently asked questions. It's got tips and basic, you know, just small things that can be done to improve healthcare access for individuals with disabilities. And then there is a National Association for Dual Diagnosis, or NADD. This group is all about dual diagnosis. They actually have a conference coming up in December. It is going to be online. So you can start by surrounding yourself with like-minded associates. I highly recommend becoming a member of NADD, attending their webinars and their conferences, just to hear, you know, the latest about how, you know, what's being done specifically for this population. And they have a ton of resources that you can access and put some of those, you know, into place in your practice. Thank you all so much for this opportunity to be here with you today. I will be around for the live Q&A. But if you have any other, you know, questions for me at any point, here's all of my contact information, my phone number at the office, and my email address.
Sorry about that. Thank you to our speakers today. Ashley McReynolds was not actually able to be with us here today, and neither was Dr. Brandy Kelly, but we do have Dr. Jan Laughinghouse with us and Dr. Tab Bounds to answer any questions. Please put any questions that you have into the chat, but as we're waiting for questions to populate, Dr. Laughinghouse, will you tell us a little bit about what happens at Capital Area Human Services for those for this population, this dual diagnosed population?
Sure. So Capital Area Human Services actually provides developmental disability services along with addictive disorder services and services for mental health disorders. And we provide the services for a 7-parish region. And we are actually the single portal of entry for people who are seeking any type of assistance for government funding program, government funded programs. And so the first thing for anyone to do if they want to get some type of assistance or find out if someone has developmental disabilities or apply for any type of financial assistance from the waiver programs that we have is to contact Capital Area. And they can actually contact us on the web by going to realhelpbr.com and sending us a message, and someone will contact them, or they can give us a call at 225-925-1910. And what will happen is someone from our entry unit will talk to them and see what their needs are and see which way they need to be guided. So we do provide lots of services, as I said, for a 7-parish region. And we have a helpful and knowledgeable staff here ready to help.
Yes, I know that you do. And I know that y'all are particularly mindful of those that need both sides of your services and working together to move them towards health and wellness.
Absolutely.
Dr. Bounds, are there any updates you have from us or programs that have started from the state's perspective or things that you see that we didn't cover here today?
I think most everything was covered, so I don't really have anything that I think is going to be new. I will just maybe remind people that we do have the OCDD Resource Center. We have clinicians across the state who are available. We work closely with each one of the LGEs. We work with the MCOs. We work with various providers. Our resource center clinicians provide consultative supports for behavioral health issues, for medical nursing issues, and for allied health issues like PT, OT, home modifications, speech, nutrition, dietitian. So it's a wide range of consultative services. We're typically not going in and providing the service, but we're consulting with the professionals who are already there in the community providing those services. We consult with them to ensure that they're taking all of the things that we've been talking about today into consideration as they're trying to support people with developmental disabilities.
Great. I mean, that it's so important to have those expertise at the state level, because we know historically the way that the dollars have come down from the state, it has siloed. And so people getting help from both sides of the spectrum has been more difficult. So I know that y'all's role at the state and then working with people like Jan to make sure that Dr. Lavinghouse and her staff to make sure that these issues are addressed together and in sync. I saw that I believe it was Clarice had her hand up. We can't open the floor, but if you could just please put the question in the chat, we'd love to answer it for you, and we'd love to hear from you. Is there anything else that either one of y'all would like to share about what's happening with our state or what you're seeing, or any that was referenced briefly post-COVID trends? We know that that's been particularly difficult for many people with mental behavioral health diagnoses, and especially a population that is dealing with dual diagnosis.
Yeah, I would say that, one of a primary focus that we've had over the last couple of years, we've talked a lot today about the DD system and the behavioral health system. So we've tried to facilitate the communication between those two systems, one by having liaisons from our OCDD Resource Center to each one of the primary MCOs, so that when we're both aware, or one side is aware of a case that's in crisis, we can effectively reach out to each other. We've also tried to bridge some communication gaps with some of the other state agencies. Often we're dealing with children maybe who are not with their family of origin, and so we're interfacing with DCFS. So we're trying to improve that communication. Sometimes we're dealing with youth and adults who've been arrested, and so we're dealing with the justice system. So we're trying to educate judges and advocates in the legal system. So yeah, it is a huge and complicated system where we're trying to get those feelers out, get our claws into some of these other systems, and see how we can work together more effectively and more efficiently for the people we're trying to support.
Yeah, so important. And as I said, unfortunately, such a new mindset, I think, for everybody to this. We're stronger together than we are apart, and we can provide services. I still don't have any questions in the chat. So wondering if there's Dr. Laughinghouse, have you seen anything particularly uptick, maybe not only with this population, but in general post-COVID, or anything that you'd like to add there?
Probably along the same lines that Dr. Bounds talked about. We know post-COVID that even people who had not exhibited any issues with mental health concerns before certainly had them post-COVID, because there was a lot of trauma that people had surrounding it, whether it was getting sick themselves, worried about their mortality, or seeing other loved ones pass away. We also saw the anxiety, particularly diagnoses of anxiety and depression, also increase exponentially, and particularly among children. It just so happens that the things that we did to not get sick physically from COVID are not so good for our mental health. Keeping distance, separating and isolating yourself from your family members, and staying inside the house. And so we know that we are now seeing the effects of that. And so we are seeing lots more children and people with diagnoses of anxiety and depression.
Yes. And I feel like that as it creeps back into the news, as we get in these upticks in these seasons of flu and just the seasons of COVID, it starts. I mean, I can feel even myself, get a little anxious about whether or not we're going to go back there again, or what's going to happen next. And so I'm sure.
Yeah, and if you think about it from a trauma-informed perspective, and you view kind of what we all went through collectively with COVID, and everyone at home and not being able to get out, as a traumatic experience, then anytime the setting is such that that's a possibility, even if it's a remote possibility, yeah, you can start to kind of have those feelings of anxiety, a little trepidation. And then for someone maybe who has a cognitive disability, who may not be fully appreciating the whole concept of the situation, that really can lead to some behavioral challenges. It can lead to depression, anxiety, and other things that we've talked about today. Yeah.
Lisa Smith has put a question in here, and she said, has there been discussion on possibly obtaining a stabilization or neuropsychiatric unit for DD individuals? They are I'm not sure what that means, early left out. They are easily left out, I'm thinking is what she meant to say.
Right. The answer to that is very complicated. Part of it is yes, there has been discussions related to that. I think the Office of Behavioral Health right now has I'm not going to get the letters right, an RFP or an RFA or an RFI, some request for a program.
Yes.
And the one that I'm thinking of specifically is for a PRTF, which is a psychiatric rehab treatment facility. So not really a stabilization unit, but a unit that would be focused on psychiatric treatment, but specifically for people with IDD, and it would be for youth. And so it would be a place that a youth could go who has an IDD, where the focus of the treatment is going to be on those psychiatric issues. We have also talked about stabilization units. The current system that we have, where you're either at home, and this is true mostly for adults, you're either at home or you're in an acute psychiatric facility, but usually only for 7 to 10 days. And then after that, there's really nothing else, right? We have the two large state psychiatric facilities, Central and East, but those are primarily for people who are in state custody and most people don't need that level of care. But if you need something more than a 7-day stay at an acute facility, there's less out there for you. So there's
Yeah.
always talk about that. You know, one of the issues with providing more of those types of settings is, you know, if you do create a 10-bed stabilization unit, I could fill it up tomorrow. And so now where's the 11th person go? And so it's like that can be part of the solution. It can't be the whole solution though, because we can't build enough facilities to create all of that. We've got to find other ways to appropriately and effectively provide treatment to people.
Yeah, I think I think that is a societal myth. I think people who are outside of the mental behavioral health care sphere don't understand that piece. They think there is a place, and unless you are prepared to really private pay, it's just not the case. I have a question for you, Dr. Lappinghouse. It said, how old must the patient be to be referred to your organization for help?
We accept children as well as adults. Because we have psychological services where we can do assessment, evaluation, and diagnosis. So we really are the single portal of entry. So we are the starting point for people who want to come into the system. So if someone suspects something may be going on with a child, they certainly can bring a child. We also have a program called Ascend, and Ascend is for children ages 2 to 7 who have a diagnosis that is on the autism spectrum, so autism spectrum disorder. And so we work with children to adults and all the way through the end of life.
Nice, thank you. Kathy Lynn Cook is asking, I'm seeing more and more children with IDD, BH, behavioral health, and the effects of trauma. As an attorney for these children, where do we start in trying to figure out what needs to happen first? Where can we find a service or provider, etc.?
Yes. Ms. Cook and I have both worked on several cases together where that has been the issue. And you know, look, I wish that I had a great answer for you. That, but each situation is different. I think the answer eventually will come from all of those different systems working together. There's such a long history of all of those systems being siloed, and you know, thinking that, well, if someone has a developmental disability, well, then it's the DD system's responsibility to provide everything that child needs. And we know that's not true. The same is, you know, if a child has schizophrenia, but also a developmental disability, it's not all on the behavioral health system to figure it out. We've got to work together to find the right combination of supports from the behavioral health system from the DD system. And I think all of the systems are struggling with that right now, and trying to figure out what is the right mix, what does it look like, where is it going to happen. You know, I tend to be pretty positive, so I try to have that glass half full outlook that at least right now we have, I think, most of the right people at the table talking about these issues. And so I'm optimistic that some solutions are going to start coming from this. Part of it, I will say, is talking to your local representatives, right? Because none of this stuff happens for free. You know, money has to be allocated. If physicians and psychologists and psychiatrists are going to provide services to people who have more complex needs, they expect to get like a complex care rate, a higher funding rate for that. And so some of this is going to have to be legislatively pushed. And so the grassroots folks are pushing that. And then those of us kind of on the inside of the systems need to be working together kind of come up with the ideas so that when and if the money is there, we have ideas to say, okay, here's how we're going to effectively and efficiently use this money to help people. I know that's not a great, here is the solution kind of answer, and it's very long term, but at this point, I think that's the best I have.
And that's why we're here today, to have these conversations and to, so also we can take the shared information, but the shared gaps to our legislators. We're going to get an opportunity to do that in January. We're going to have lots of newly elected officials, and Louisiana Mental Health Association is going to help make those connects, so you can connect with them before they come to Baton Rouge, to tell them these kinds of things are important and needed in our state. In fact, Sandra Trammell says, I would like to see a PRTF and a stabilization unit to help the complex acute cases that regular IP unit is not capable to handle, instead of sending the children out of state. So I think that we can all say that, and those are the kind of things that are important for our legislators to hear, because if they don't hear it from us, they don't know about it. And we know that that's the case. Dr. Laughinghouse, to close out, we're a minute over our time here. Thank you. That is just what I was going to ask you to do.
You're welcome. I saw the questions.
I love it when the ESP is working. Well, thank y'all so much today. Are there any, Dr. Laughinghouse put the information here, and especially for the Ascend, are there any other questions? We will not be sending the slides out. That was a question specifically, but we will put the recording of the whole event on our website, so that you will be able to review it and listen to it again if there was some information that may not have been as important today, but you may need it tomorrow. So we want to make that readily available for you. Anything in closing that y'all would like to add? We're grateful for your time and for having this incredible conversation about a very complex issue.
The only thing I would like to say is that if you don't know where to start, reach out to Capital Area and give us a call, and we can figure it out together.
Right. And I would just add to that, if you're not in the CAP area catchment area, reach out to whoever that local governing entity is in your area. And that is the best place to start.
Absolutely. Thank you.
Yes. Thank y'all. Have a great rest of your Friday and a lovely weekend.
Thank you.
too.
Bye-bye.